Hey guys, Dr. Justin Marcagiani here. Today's video is going to be on why conventional medicine misses low thyroid function or functional hypothyroidism. This is a question I get all the time. I see lots of patients with hypothyroid symptoms. They may even be diagnosed with hypothyroid already. They may not even be diagnosed at all. And so we'll kind of go into the physiology and why this gets missed. And before we do, please smash that like button. Really helps the search algorithm. Put your comments down below on this topic of thyroid and why it may get missed in the conventional medicine side. Please put your comments down below. All right, so let's dive in. So first off, hypothyroidism from a conventional medical standpoint is typically going to be just an elevated in the TSH. That's your primary hypothyroid, where your TSH is either above 4.5 or 5.5, depending on what lab range you're in based on what part of the country you're in. There's different lab ranges based on the country, but usually between 4.5 or 5.5. Conventional medicine will say, hey, we got a potential hypothyroid issue. Maybe they'll run a T4 as well. And typically if T4 is low, or if T4 is even normal range, if there's hypothyroid issue, most people in conventional medicine world will prescribe some form of Synthroid or Levoxyl or levothyroxine, some type of some tetrathionine with a sodium chloride molecule on there to bring that TSH down to closer to a 1, right? They want to take that overstimulation of that pituitary producing thyroid stimulating hormone. They want to bring that down. The goal is if the TSH is elevated, it's because it's trying to scream to that thyroid, make more T4, right? So we have triiodothyronine, which is T3, and then tetra, which is 4 iodine molecules bounded to that tyrosine compound. So tetraiodothyronine is your T4 or levels, right? Your thyroxine and your T4 levels. And so TSH is screaming down to make more of that T4. And again, if your TSH is really high, then the thinking is that your brain is struggling to get your thyroid levels to the place it wants to be. And so the goal is you're giving some thyroid hormone that's going to increase the T4 a little bit. That's going to then have this feedback loop that goes back to the TSH saying, hey, you can relax. You don't have to yell at the thyroid gland. We're making enough thyroid hormone. It's kind of like if you have kids, everyone knows this. If you have kids, they don't kind of do what you say a lot of times. You have to maybe raise your voice a little bit to get your attention. It's the same kind of thing in regards to the volume increasing. Now, conventional medicine is really good at using TSH as a good marker to diagnose a primary hypothyroid issue. The problem is, how long does it take for someone to have symptoms with their thyroid and for their TSH to elevate? That is the gold standard question. That's where it's all about. A lot of times it can be between 5 or 10 years where someone can be struggling with thyroid symptoms. Their thyroid starting to dysregulate. Functionally, their thyroid is not where it should be at an optimal level. Symptoms are starting to occur. Anything from anxiety, irritability, cold hands, cold feet, hair loss, eyebrow thinning, sleep issues, weight gain. All of these issues could be starting to brew. And while we're waiting for this TSH diagnosis, you could be suffering for 5 or 10 years. That's the problem. Not to mention in this whole analogy with TSH, what if we have an autoimmune issue that's happening in the background and we have these antibodies that are being produced, right? Let's say thyroid peroxidase or TPO or thyroglobulin antibodies. They could be going after and attacking your thyroid gland. And if your thyroid doctor is only looking at TSH, they're missing a big part of the equation because according to the data, 50 to 90% of thyroid issues are autoimmune in nature. I personally have an autoimmune thyroid issue. I ran my thyroid labs just maybe 2 weeks ago. I can share them with you in another video, and we can talk about that down the road. But if you have these autoimmune antibodies happening and occurring, they could be attacking the thyroid gland. They could be causing the thyroid tissue to spill out thyroid hormone. That could also be affecting the TSH because if you're attacking the thyroid, you're spilling out hormone. More hormone comes out, kind of like you stab someone with a knife and some blood comes out. You stab the thyroid with some antibodies, some hormone comes out that could lower that TSH as more hormone enters circulation. So you can see if you're using this TSH as the end stage indicator, it may cause a long deviation between you having problems and it actually coming up on a test. And that's why people suffer for so long if you're only looking at TSH as an issue, as the only end stage marker. Now, if you have elevations in TSH, you definitely have a thyroid problem. That's like without a doubt. Now you have to go look downstream and look at the different patterns that could be at play, but you definitely have a pattern of a thyroid issue there. Now, would giving thyroxine or T4 be enough to fix or correct that issue? Most of the times, no. I mean, you'll get that TSH down, which is good because you don't want to overstimulate the thyroid. You could develop a goiter and swelling and things like that. So you want to get that TSH down for sure. But you have to look downstream, right? Is there autoimmune issues going on in the background? Because if you have autoimmune issues, well, you can guarantee that thyroid's going to get beaten up over the years, and you'll need more and more thyroid dosing. Also, you're going to be having issues with thyroid hormone receptor sites working because of all the inflammation on the antibodies. That's going to be interfering with the hormones and docking into receptor sites. Also, you're just going to prolong the attack. You're not fixing the attack. So if you see antibodies, we need different approaches in regards to modulating the immune system. We need to be looking at glutathione levels. We need to be looking at vitamin D levels. We need to be looking at selenium, all these important nutrients to calm down the immune response. Are you eating gluten? Are you eating dairy? Are you eating processed foods? Because the diet and some of these autoimmune immune modulating nutrients like glutathione and vitamin D play a huge role in calming down the immune system. I've seen patients with antibodies hundreds of times outside of the reference range, and they've been able to slowly over time bring them back into range by making some of these changes. So if your TSH is elevated and you have all these autoimmune markers going on in the background, it is going to be a detriment to not know about that. So you want to have the complete picture. Now, why doesn't conventional medicine test those antibodies? It doesn't change anything. Right? In conventional medical world for autoimmune issues, usually there's medications that have a lot of side effects, right? Whether they're biologics or immune suppressants or some kind of a steroid or prednisone, these type of drugs are used where there's significant amounts of autoimmunity, whether it's a Crohn's flare or a significant autoimmune arthritic issue, right? They're not used when the symptoms are mild because the side effects are pretty bad. So usually with the old adage of do no harm, right? The Socrates model, or I should say Hippocrates model of conventional medicine, they're not going to prescribe those medications because they don't want to cause more problems than the symptoms you already have. So those drugs will not be used. Therefore, there's no reason to run antibodies if there's no treatment available for markers that are elevated. Does that kind of make sense? And so because, hey, antibodies are elevated, well, we don't have a tool for it, so we're not going to run it because insurance is only going to pay us if we can run a test that allows us to prescribe a drug based on the data. So they're going to run your TSH, that's it. Sometimes you'll run a T4, maybe if you're lucky, and you're going to just be given a T4, a synthetic tetraiodothyronine with a sodium molecule kind of drug. Levoxyl, levothyroxine, Thyroid. That's basically what the treatment looks like. Now, we're not addressing the autoimmunity. We're trying to get TSH down. Sure, that's good. Trying to prevent a goiter from forming. Yeah, that's good. We're not looking at the nutrients. Some people may need small amounts of iodine. Again, if there's autoimmunity, you got to be very careful with giving anything more than the RDA for iodine, maybe a couple hundred micrograms max. If it's autoimmunity, you really want to focus on other nutrients like magnesium and selenium and zinc. They really help calm down inflammation and modulate the immune response. Iodine can sometimes be like throwing gasoline on the fire. So you got to be very careful if you're going to come at it with iodine, right? Tend to wait a little bit, tend to really make a lot of the diet changes and lifestyle changes. Work on blood sugar too, because if your blood sugar is up and down, lots of processed food, lots of carbs, that can definitely put your immune system on a roller coaster ride too and overstimulate the immune system. So very important as well. So we talked about TSH, late stage, 5 or 10 years plus. We talked about the autoimmune. We talked about the nutrients that aren't looked at. Also, we have this T4 to T3 conversion issue as well. So if we're just giving T4, that's your synthetic T4 molecule, that's relatively inactive for thyroid. It gets converted from T4 to T3. T3 is now your active thyroid hormone. So why does this matter? Well, there's an assumption that if we just give T4, it's all going to magically trickle downstream to T3 and get converted and activated properly. That may not happen. The more inflammation there is with antibodies, the less likely that T4 goes to T3. The more we have nutritional deficiencies like zinc, selenium, magnesium, CoQ10, the less that's going to convert. The more we have insulin resistance, right? T4 to T3 may not convert. So lots of carbs, lots of high blood sugar. There's all kinds of studies with diabetics having low triiodothyronine. That's T3. Type in diabetes or insulin resistance and triiodothyronine being low. You'll find all kinds of studies showing low T3 with diabetics and pre-diabetics because insulin, high levels of it, plays a major issue with the converting of T4 to T3. Also, on the other side, if you're on a very low diet and you have very low insulin, guess what? You may also see poor T4 to T3 conversions as well. That's why if you undereat and you kind of starve yourself, you're on a very low calorie diet, what starts to happen? Cold hands, cold feet, hair loss, tired, right? Why? The same kind of symptoms almost as a person that's hypothyroid because your body is trying to conserve energy. Don't have a lot of energy. So why are you going to increase your metabolism if you don't have much to burn? Why are you going to stoke the fire higher if there's no wood to throw on the fire. Does that make sense? And so you can actually cause similar issues with low insulin. So high insulin, too much processed carbs, sugar, that such, yes, that can affect T4 to T3. But now also starvation type of diet, low insulin now, yeah, that can also affect T4 to T3. And then also stress hormones like cortisol, high levels of cortisol can also impact T4 to T3 conversion. Again, cortisol is a anti-inflammatory stress hormone. So when your body's under lots of stress, think of you're creating a metabolic fire of inflammation. Your body's going to use cortisol to quench that fire. If you have chronic high or low levels of cortisol, that will also impact conversion of T4 to T3. Think about it this way. When your body's stressed and inflamed, it doesn't want to increase metabolism. When your body's low and chronically stressed, it does not want to increase metabolism for the same reason. So in general, you got to look at the big T4 to T3 converter issues. And then, of course, all the nutrients we talked about. If you have gut issues, guess what? All those nutrients have to go in through your diet, a healthy diet, assuming that's good, have to be broken down by good enzyme and acid levels, and have to be absorbed and assimilated as well. So if we have poor gut issues, SIBO, dysbiosis, that can be a problem. Certain bugs can also exacerbate the autoimmune response. Lots of studies showing H. pylori, blasto, can increase autoimmunity. So you got to look at the whole gamut when you have a thyroid issue. This is why most thyroid doctors will miss it. One, we have late stage indication with TSH. They're not going to look at antibodies because it doesn't allow them to prescribe a drug or a treatment that changes care. And then also, doctors stay in their lane. If they're a primary care, if they're a endocrinologist, they're not going to act like a gastro. They're not going to act like a neurologist. They're not going to act like a dietitian. They kind of stay in their lane. But really, to be a great functional medicine doctor, you have to be an ultra generalist, right? You have to be able to have a foundational understanding of endocrinology, gastroenterology, neurotransmitters, neurology, nutrition, right? Blood sugar issues, the whole 9 yards. You have to understand the whole gamut. And this is why a lot of times conventional medicine will miss some of these things, right? Hope that makes sense. Hope you guys enjoyed today's video, and it kind of gives you the ability to kind of zone back, look at the thyroid, understand the different tracks of functional medicine and conventional medicine. With functional medicine, we are looking at the overall function of the body. We are understanding, hey, we have some lab markers. We're using more sensitive metrics for labs. We're using TSH in a functional range, 0.5 to 2.5. We're using T3 and T4 within a functional range. We're looking at antibodies. If we see the functional range start to deviate, start to know, hey, something may be wrong. We're not going to let things get so out of whack where it has to be outside of the pathological range for us to start looking around. We're going to have a sensitive range, so we start picking things up sooner and not let the patient get sicker and have more problems. Hope that makes sense. We're trying to go upstream versus downstream, looking at the underlying systems, because the systems, when they're out of balance, the symptoms will manifest downstream. So I hope you enjoyed today's video. And this is Dr. J. If you want to reach out, I'm available worldwide for functional medicine support and consultation. There'll be links down below to reach out to myself and colleagues. Hope you guys enjoyed today's video. Let me kind of dive into a couple of questions, see what's up here. All right, can you explain how a chronic viral infection contributes to thyroid problems? I mean, there are certain infections like EBV, Epstein-Barr virus, cytomegalovirus. You can look at the research out of Dr. Pender, I think out of New Zealand or Australia. He talks about these infections throwing off the immune system. So if you already are more prone to having an autoimmune response to your thyroid, maybe you already have antibodies, it's possible that could upregulate those antibodies more and facilitate a greater thyroid attack and then thus decrease your hormone level. So that's where that would come from. And so you got to really get to the roots of where that virus is coming in. Most virus issues are opportunistic. So usually your immune system has to be weaker for them to even have a problem to begin with. So you got to look at the gut, got to look at the diet. There are some nutrients and herbals and medicinal mushrooms you can do that will also help with virus issues too. My T3 is only just over 3, and I've recently started itching badly. Is this due to histamine? What could I do? So if your T3, I'm guessing your T3 free is over 3, because usually T3 totals in the, close to 100 range is good. So T3 free up over 3 is good. I mean, I'd like to see everything else. I'm not sure your symptoms are related to your thyroid. It does sound like some potential histamine. Could be some fungal issues too. I mean, do you have dandruff? All these things could play a role. There could be some SIBO and fungal overgrowth that's connected to the histamine. Again, histamine is essentially a neurotransmitter released by your basophils in your gut, in your white blood cells. So your white blood cells have neutrophils, lymphocytes, monocytes, eosinophils, basophils. A basophil outside of your blood, once it goes into the tissue, becomes a mast cell, and mast cells can produce histamine. And so when you have histamine issues, usually there's something inflaming the body that's causing that response. Do you treat SIBO before thyroid? It depends. If someone comes in with a thyroid issue and let's say their TSH is high, right? Well, that's rule of thumb. Like, you have best practice, you have to get that TSH down closer to 1. That's like out of the gates. Now, again, do you do it with the natural thyroid desiccated glandular? Or do you use it with a synthetic medication? Typically, that's going to be up to the patient and the doctor. But that we're definitely going to be working on all the nutrients, and we're going to look at, is there autoimmunity? Is there a thyroid conversion issue? Do we have insulin problems? Do we have cortisol problems? So all those other potential mechanisms, we want to look at them and lay them out and say, which mechanism is the most important here? Which is the largest, the mechanism that's the most out of balance, if you will. So we look at everything side by side. But of course, we're going to work on all of the foods, the blood sugar, the nutrients, the diet, the inflammation, the antibodies. We're going to look at everything and then come up with a treatment that makes sense based on that pattern. Good question, though. I'm going to start taking natural desiccated thyroid, NDT. That's good. I like that. I mean, I like natural desiccated thyroid because, number one, there's T4 and T3. So if you have a conversion issue, you have some T3 in there. You're also going to have some T2. T2 is not even looked at, right? That's diiodothyronine. You have tetraiodothyronine, that's T4, triiodothyronine, and then you have diiodothyronine. So T2 is actually shown in the literature to be very helpful for metabolism and weight loss, but they don't really test it in conventional medicine. In the scientific literature, it's tested. So you're going to get some of that in a glandular. You'll also get some protomorphogenic proteins. There's some data showing glandulars actually can reduce antibodies due to these things called PMGs, protomorphogenic compounds. And so I like that. There's also some calcitonin and other nutrients in the glandular tissue. So I like that. You get a little bit more of a wider spectrum. Again, if you're going to take T4 and you have Hashimoto's, for instance, much bigger fan of something called tyrosine, which actually has T4 in there with the sodium, but it has it in a liquid gel cap, so better absorption. And it doesn't have the corn starch fillers that a lot of the Synthroid and levothyroxine molecules have. So if you're really sensitive to gluten, that corn starch can sometimes be a molecular, I should say, kind of a molecular mimicry thing with gluten and aggravate that immune response. It's very possible. All right, guys, awesome. Great questions today. Well, hope you enjoyed today's podcast. If you did, put your comments below. Again, feel free to share with family or friends that have potential thyroid issues. And again, you want to understand where conventional medicine is coming from. If you understand where they're coming from, then you're going to be able to work with them better. And then you're also going to be able to find a functional medicine practitioner that can dovetail with that or can help carry the baton where maybe your conventional person is not living up to what they should be doing. Hope that makes sense. Other tests available to measure levels of T2, not in the clinical setting, in a research university setting, yes, but not in a clinical setting yet. All right, guys, good questions today. Have a good one, guys.